crescents, active lesion. This is class 3 lupus, and you will find mesangial deposits. This is again a segmental
Endocapillary
endocapillary
hypercellularity.
hypercellularity with fibrinoid necrosis. And this is a membranous lesion, class 5, with membrane thickening, better appreciated on the Jones silver with the spikes. And this is a class 6 where we find more than 90% sclerosed
Sclerosed
glomeruli.
glomeruli. And this is
This is the
the
schematic diagram of the
right.
EM picture where in the class 1 there are only a few mesangial deposits. In the class 2 there are mesangial cells increased in the mesangial area. In the class 3 and class 4 there are neutrophils accompanying these mesangial cells. And class 5 there are subepithelial deposits. Class 5 and 4 both subepithelial and subendothelial deposits.
Right,
These are
ma'am.
all the
So, what should be the reporting protocol in the kidney biopsy of this
The
patient?
reporting
And what
protocol is
information
same
should
as
we share?
other pathology structure report, but here while reporting kidney biopsy, one has to adhere to the fixed layout and structure covering all the aspects of biopsy in a sequential manner. So first,
Right.
the gross examination, we have to report the number of codes that have been submitted, what is the length of the core, and on the microscopic examination, we'll proceed in a sequential manner describing all the 4 compartments, starting from the glomeruli, tubules, interstitium, and blood vessels. And the glomerular lesions, we have to say how many are sclerosed, whether there are any segmental lesions, and comment on the capillary thickness, the mesangial hypercellularity, or endocapillaries and crescents. All that has to be mentioned. In the tubuloid interstitial compartment, the chronicity and interstitial fibrosis and vascular lesions, whether there are hypertensive changes or diabetic.
Right.
And IF, we have to combine all these
With the
LM
immunofluorescence
features and
findings.
IF and give
Yeah.
a final report.
So, Upalda, are you okay with the information which we share usually with the clinicians, or anything more you need to add it?
So yes, the biopsy finding that we see with the report, the need with the report is the description of the biopsy and the activity and the chronicity index. But this is, you must understand that the ISN RPS classification has mainly 2 limitations. That ISN RPS classification mainly deals with the glomerular disease. But we understand that there is an evolving concept of lupus podocytopathy.
Right.
That we should know that is not addressed in ISN RPS classification. The lupus podocytopathy should be suspected in somebody who is having a nephrotic range proteinuria. The biopsy might be absolutely normal, a minimal change morphology. The electron microscopy may be all negative, and the immunofluorescence. And there is a need of the electron microscopy where you have a negative, a minimal change morphology in the histopathology, and the immunofluorescence is not showing the full house that we usually see. In this case, the pathology of lupus is podocytopathy. That's picked up only in electron microscopy. That's been kept out of the ISN RPS classification. One more important thing is you must understand the presence of thrombotic microangiopathy in lupus. The presence of thrombotic microangiopathy in lupus makes the management entirely different from what is the present management of proliferative lupus nephritis.
Okay, okay. We will keep in mind. And sir, how to manage this case, Professor Ghosh?
Yes. So basically, whether it's a proliferative subendothelial predominance or subepithelial predominance, that's the issue. So once it's a class 4, classically, so immunosuppression induction followed by maintenance. The important issues are for young female patient, that's the majority of our patient, cyclophosphamide. Certainly it has been proved nowadays that till 25 years, one can go with cyclophosphamide, and that's the best responsive therapy for our population, along with corticosteroid. And corticosteroid certainly not 1 milligram per kg per day, but 0.5 milligram per kg per day. And up to 4 weeks with the same dose, gradual reduction. And cyclophosphamide as we are giving, so regular NIH protocol. And for maintenance, certainly we can go with mycophenolate or azathioprine like that one. And azathioprine, mycophenolate possibly has got the same issues. So we need to regular monitor with the blood count, with the routine urine, and every 6 months, as we are discussing, complements and dsDNA. That gives a clue. I mean, otherwise, if there is relapse of proteinuria, one have to go for a repeat biopsy. And there we need to check for, as we are talking, whether it has not responded or it has responded but it's progressing, or there is thrombotic components like APS or thrombotic microangiopathy. So these are the issues to be taken care of.
Thank you, sir. That is the follow-up protocol for this patient. So we have come to end of these two interesting cases and closing the session. Thank you all the distinguished panelists for coming from their busy schedule and come here and enlighten us. Thank
Thank you,
you.
Saurav. Thank you, Saurav, for framing, two fantastic cases. Okay.
Thank you.
Thank you, sir. Thank you, ma'am. I will now ask Dr. Saurabh Bhomik to please felicitate each of our panelists. Chole jao. Professor Dr. Olokendu Ghosh, sir. A big round of applause, please. Dr. Rupal Sengupta, sir. This was a very eye-opening, mesmerizing session. Thank you all participants, all panelists and our moderator. Dr. Bashop Bijoy Sarkar, sir. Sir, thank you, sir. Sir, please stay back, sir. Sir, Dr. Benzi, sir, there is a certificate for you, sir. Please come. A certificate. There is no applause. What is wrong with all the cap people? Madam, will you say something? No, silence is only during the discussions, the talks and all that. Not during the felicitations, please. Dr. Shonita Chatterjee, madam. Thank you, madam. Madam also conducted a renal immunofluorescence workshop yesterday at Medica, which was highly successful, as were the other workshops. And Dr. Rajoshi Sarkar, sir. Thank you so much for giving us all your valuable times. And Dr. PBS, sir, we have kindly held you back to felicitate Dr. Saurabh Bhomik. Dr. Shavasi, ma'am.
Yes, Saurabh was very apprehensive about conducting a session with such esteemed panelists, and I think he did a wonderful job. Well done.
Thank you, ma'am. Thank you everyone. So we'll just take a moment of your time to reshuffle the stage. We'll begin our next session. And in this time, I will also call forward our winner of the poster prize. Priyadarshini is here. Priyadarshini, can you please come forward? Dr. Shilaj sir, are you here? Dr. Tulika Lipi ma'am, please come, please come. I've spotted Dr. Tulika Lipi ma'am. So while we rearrange our stage, Priyadarshini, please come forward. Her topic was about coagulation.
Yeah, clinicopathological profile of coagulation factor inhibitors.
And Priyadarshini, where are you from?
I am an assistant professor working in PSG Institute of Medical Sciences, Coimbatore, Tamil Nadu.
So our national participant, Dr. Tulika Lipi ma'am, come. Ma'am, please come. Dr. Jyoti Chaudhary.
All our CAP members in the audience who've come to attend this conference, engage with the conference and please applaud every person who speaks well and every person who's taken out time to present before you. Thank you.
Thank you, ma'am.